A very good afternoon, everyone, and welcome to the ICA Online PG classes. Today is slightly different because we have our own secretary, normally Dr. Naveen Malhotra sir, who welcomes everybody and starts off the classes, these ICA Online PG classes, which are held every Monday morning, Monday evening. But today, sir is on an aircraft right now, so I'm sure he'll be joining in as soon as he is able to. In the meantime, for the benefit of the audience, we would like to say that the ISA Online leadership holds these classes every Monday by 5 p.m., in which speakers of national repute spare their valuable time and effort to teach the postgraduates and also the young faculty regarding various topics of interest for the postgraduates. And today is no different. Today we have a very, very reputed teacher amongst us, and she per se does not need much introduction. However, for the benefit of the uninitiated, today we have with us Dr. Aruna Parameswari, madam. She is currently the professor and head of Department of Anesthesiology and Pain Medicine at Sri Ramchandra Institute of Higher Education and Research, Chennai. She is the Vice President, Association of Obstetric Anesthesiologists of India, and she's the adaptation editor of the prestigious Stolting's Coexisting Diseases for the South Asian edition. She's the member of the Specialist Board in Anesthesiology of the National Board of Examinations, the DNB, and she's a vastly experienced teacher with more than 200 lectures in various conferences, 24 publications, and 10 book chapters. She has special interest in teaching anesthesiology, and apart from that, she has interest in obstetric anesthesia, pediatric anesthesia, anesthesia machines and equipment, blood transfusion, and airway. So a very warm welcome, ma'am, and welcome to the ISA Online PG classes. It is an absolute honor and privilege that you could spare your valuable time for the sake of the postgraduates and all the audience and listeners. Ma'am, this is the 39th class of the series of the ICA Online classes. And what we normally do is that all the audience members are muted till the time your lecture is going on. Just in case there are any questions that the audience might have, they can type it in the chat box. And in case there are any questions which you might have, the audience is encouraged to type the answers in the chat box itself. So today, ma'am will be discussing the anesthetic considerations of chronic renal failure for renal transplantation. Over to you, ma'am.
Hello and a very good evening to everyone. Thank you, Dr. Nishant, for those kind introductory words. At the outset, before I begin, I would like to thank Dr. Naveen Malhotra and the entire team at ISA for this opportunity to be a part of this online PG teaching program. I think you are all doing an excellent job doing this online PG teaching every Monday. And it's an honor and a privilege for me to be a part of it this Monday. Thank you so much for that. Can I start sharing my screen, Dr. Nishant?
Please, madam. Yes, we can see your slides, ma'am, and you're audible. Thank you.
Okay. So thank you so much. So in the next 1 hour to 1.5 hours, we are going to be taking a look at anesthetic management of a patient with chronic kidney disease for renal transplantation. So the outline of my class is going to be, we'll be talking about what is chronic kidney disease, how do we categorize it, what is the effect of chronic kidney disease on the different organ systems in the body. Then we will move on to anesthetic management of a chronic kidney disease patient for renal transplant, where we will look at preoperative assessment, preparation and optimization, intraoperative care, and then postoperative care. In the middle of my lecture, I have interrupted it with some multiple choice questions. So as and when the questions come, Dr. Nishant will be reading out the question to you, and I request all of you to type your answers in the chat box, and then we will discuss the answers as well. So we'll move on to the class now. So the first question is, what is chronic kidney disease? So the KDIGO, which is the Kidney Disease Improving Global Outcomes Group, has defined chronic kidney disease as abnormalities of kidney structure or function that is present for more than 3 months with implications for health. So the criteria for classifying as chronic kidney disease is the presence of either one of the following And that has to be present for more than 3 months. So what are these? These are either markers of kidney damage or a decreased GFR. So what are these markers of kidney damage which are used to define the presence of chronic kidney disease? The first and foremost is albuminuria, which is defined as an albumin excretion rate that is more than or equal to 30 milligrams over 24 hours. It can also be defined in terms of the albumin creatinine ratio. When the ACR is more than or equal to 30 milligram per gram or more than or equal to 3 milligram per millimole, it is called as albuminuria. So that is the first marker. The other markers are the presence of urinary sediment abnormalities, like the presence of RBC, WBC casts and granular casts. The third is the presence of electrolyte and other abnormalities due to tubular disorders. The fourth is abnormalities detected by histology. And fifth is abnormalities detected by imaging. And the sixth is history of kidney transplantation. So out of these six, one or more are present, then it is called as chronic kidney disease. Or if the GFR is decreased, if the glomerular filtration rate is less than 60 ml per minute per 1.73 meter squared body surface area, then it is also called as chronic kidney disease. So the categorization of chronic kidney disease is based on three factors: the cause of the chronic kidney disease, the degree of fall in the glomerular filtration rate, and the extent of albuminuria. Let's look at each of these now. If you look at the categories of glomerular filtration rate, it is classified from G1, G2, G3A, G3B, G4 till G5. So G1 refers to a glomerular filtration rate which is more than or equal to 90 ml per minute. We are all well aware the normal GFR is approximately 120 ml per minute per 1.73 meter squared body surface area. So G1 is anything which is more than 90 ml per minute, and that is considered normal. G2 is when it is 60 to 90, and this is 60 to 89, and this is called as mildly decreased. G3 has two parts, G3A and G3B. 45 to 59 GFR is G3A, 30 to 44 is G3B. So this is mild to moderate or moderate to severely decreased GFR. G4 is when the GFR is 15 to 29, which means it's severely decreased. And G5 is when it is less than 15 ml per minute per 1.73 meters squared, when it is called as kidney failure. So these are the categories of glomerular filtration rate. But in the absence of any markers of kidney damage, G1 and G2 do not fulfill the criteria for chronic kidney disease because it has to be less than 60 for us to classify it as CKD. Just like GFR, we also have to look at the categories of albuminuria. There are three categories: A1, A2, A3. A1 is when the albumin excretion rate is less than 30 milligrams in 24 hours. When it is 30 to 300, it is A2. And when it is more than 300, it is called as A3. Similarly, it can also be classified based on the albumin creatinine ratio as less than 3, 3 to 30, and more than 30. So A1 is normal to mildly increased, A2 is moderately increased, and A3 is severely increased. Now, why are we defining chronic kidney disease in terms of the GFR of less than 60 ml per minute and in terms of albuminuria? This is because if you look at the all-cause mortality or cardiovascular mortality, you find that there is an acute increase in mortality, both all-cause mortality and cardiovascular mortality, when the GFR starts falling less than 60 ml per minute. Similarly, albuminuria is also important. The three lines which you see there as black, green, and red refer to A1, A2, and A3. So you find that as the extent of albuminuria increases, the risk of mortality also increases. So this is the reason why importance is given to a GFR less than 60 ml per minute and the presence of albuminuria to define chronic kidney disease. So if you look at this chart, you find that when GFR is in G1, G2 category and albuminuria is A1, it is a very low risk. It is colored green. Once it becomes G3A, even if it is A1, it becomes yellow. Or if G1 and G2 has A2, it becomes yellow, which means the risk is moderately increased. Similarly, as the GFR falls and as the albuminuria increases, the risk keeps increasing. So when do we call it end-stage renal disease? This is a clinical syndrome characterized by renal dysfunction, which requires renal replacement therapy. By renal replacement therapy, we mean dialysis or renal transplantation. So when the patient is at this stage where mandatorily for survival, the patient needs either a dialysis or a renal transplantation, then it is called as end stage renal disease. And this usually correlates with a GFR less than 15 ml per minute per 1.73 meters squared. So it includes CKD stages G4 and G5. Now, how do we evaluate the glomerular filtration rate? We're going on talking about GFR to define chronic kidney disease. So how do we evaluate the glomerular filtration rate? This is by using endogenous filtration markers. The most common marker used is serum creatinine because it's easily filtered at the glomerulus and does not undergo much reabsorption or secretion by the kidney. So we use serum creatinine as part of a GFR estimating equation like the MDRD equation, which is the modification of diet and renal disease study equation, or the CKD EPI equation, which is the chronic kidney disease epidemiology collaboration equation. So these two are the most commonly used equations to estimate the GFR and get an eGFR value. Instead of creatinine, we can also use serum cystatin C, but this is more commonly used for confirmatory testing. Similarly, we also have the Cockcroft-Gault formula where the creatinine clearance is given as 140 minus age into weight divided by the plasma creatinine into 72. This has to be multiplied by 0.85 for women. Now, why are we looking at estimations of GFR and not only on the serum creatinine value alone? Serum creatinine tends to be influenced by factors like age, sex, muscle mass, and diet. The other reason is it is insensitive to mild to moderate decreases in GFR, which means we can have as much as a 50% reduction in the GFR with the serum creatinine still in the normal range. That is why creatinine-based prediction equations have been developed to estimate the GFR to define chronic kidney disease instead of defining chronic kidney disease in terms of serum creatinine alone. Now, how frequently are we likely to come across a patient with chronic kidney disease in India? So if you look at the prevalence of CKD in India, it's about 17.2%, and 6% of patients are in CKD stage 3 or worse. And because of poor access to care, more than 50% of patients are likely to see the physician for the first time when they're already in end-stage renal disease. So they will be requiring either dialysis or renal transplantation. So what are the causes of chronic kidney disease? The commonest causes are glomerulopathies like diabetes mellitus. It can also be due to membranoproliferative glomerulonephritis, post-infective glomerulonephritis, IgA nephropathy, systemic lupus erythematosus, and amyloidosis. Besides glomerulopathies, chronic kidney disease can also be because of tubulointerstitial diseases like analgesic nephropathy, reflux nephropathy because of pyelonephritis, myeloma kidney, sarcoidosis. Systemic hypertension is again a very common disease which results in chronic renal failure and chronic kidney disease. Polycystic kidney, renal vascular disease, and obstructive uropathy. So of all these diseases, one of the commonest reasons in India is diabetes mellitus, closely followed by hypertension as the common causes of chronic kidney disease in India. We'll now take a short break to look at 3 multiple choice questions.
Yes, ma'am.
So the first question.
So the first question by ma'am is, what is the normal urine albumin in a young adult? The options are A, 10 milligram per 24 hours, B, 30 milligram per 24 hours, C, 50 milligram per 24 hours, or D, 100 milligram per 24 hours. So the first response was by Dr. M.S. Karthi, and it is mainly between A and B with a more preponderance of the option B, that is 30 milligram per 24 hours.
Okay, so the answer is actually in a young adult, it's usually only around 10 milligram for 24 hours. The 30 milligram is the upper limit of normal. So the answer is A. A is the correct answer.
Answer is A, 10 milligram per 24 hours. So that is the normal urine albumin in a young adult.
Now we move on to the next question.
Next question. So the next question is, what is the normal urine protein? A, is it less than 150 milligram per 24 hours? B, is it less than 500 milligram per 24 hours? Is it C, less than 750 milligram per 24 hours? Or D, is it none of the above? So all the audience is encouraged to again type their answers in the chat box, and this time it is a predominant A, less than 150 milligram per 24 hours. There is an occasional D also, madam, none of the above.
Okay, so A is the correct answer. So when you're talking about albumin, it is 10 milligrams. When you're talking about total protein, normal is less than 150 milligram in 24 hours. So A is the correct answer. Very good. I'm very happy that everyone got the correct answer.
Yeah, most of them have got the correct answer.
Very good. Excellent. Now we go on to the third question.
So the third question is, what is the commonest cause of CKD in India? Is it A, hypertension, B, polycystic kidney, C, diabetes mellitus, or D, analgesic nephropathy? The most common cause of CKD in India. And I think there is an overwhelming response for diabetes.
Very good. Excellent. I'm very, very happy.
Yeah.
It is correct. Diabetes mellitus is the commonest cause of chronic kidney disease in India.
There has been a very brisk and quite a lot of responses, ma'am. That is very
I'm
nice.
very happy that everyone is alert and interested. It's really nice and heartwarming.
Yes.
Okay, so we'll continue with the lecture now. So before we go to chronic kidney disease, we need to know what are the normal functions of the kidney. So this acronym is commonly used to describe the functions of the kidney. It is called a wet bed, where A stands for acid-base balance. So kidney is necessary for maintaining acid-base homeostasis. W stands for water balance. E stands for electrolyte balance. T is for removing toxins and waste products from the body. B is for blood pressure control. E is for erythropoietin production. And D is for vitamin D activation. So these are all the functions of the kidney. So what will be the clinical manifestations if the kidney does not function? So what are the organs which are going to be affected? So if you look at the clinical manifestation, it can affect fluid and electrolytes. It can affect the hematology. It can affect the cardiovascular system, the central nervous system, the respiratory system, and the gastrointestinal tract. So let us take a look at each one of these now. Let us start with fluid balance because it is very, very important. Now, so chronic kidney disease is going to cause dysfunction in regulating water homeostasis because there is going to be a reduced glomerular filtration rate, leading on to renin-angiotensin aldosterone activation and secondary hyperaldosteronism. So there is always a volume overload, which is seen in these patients. At least a 10 to 30% increase in extracellular fluid will be there in all stages of CKD. This fluid overload will lead to edema, hypertension, as well as electrolyte imbalances. Not only that, this fluid overload itself causes further worsening of CKD, and it also leads to cardiovascular disease, which can lead on to further morbidity and mortality. They can also have impaired concentrating ability, which means they cannot compensate for an extra renal loss. So these patients, although they have a volume overload, they are likely to have hypovolemia and hypotension also when they have an extra renal loss. From fluid, let's move on to electrolytes next. A number of electrolytes tend to get affected in kidney disease. Sodium, potassium, calcium, magnesium, phosphate, and bicarbonate. So sodium, if you see, the commonest change is hyponatremia. This is usually a dilutional hyponatremia. Potassium, hyperkalemia is very common. Calcium, there is hypocalcemia. Similarly, there is hypermagnesemia and hyperphosphatemia. And decreased bicarbonate is associated with metabolic acidosis. So let's take a look at each of these now. So if you look at hyperkalemia, you find that most of the potassium secretion actually takes place in the distal part of the nephron. So serum potassium concentrations are maintained within normal limits till the GFR is 10% of normal, at which point the hyperkalemia manifests. This is because in the early stages when the GFR falls, the remaining nephrons tend to compensate. Not only that, we said there is a secondary hyperaldosteronism. This hyperaldosteronism will also lead to increased potassium excretion. But these compensatory mechanisms can easily be overwhelmed and with an increased risk of hyperkalemia if the intake is more, or if there are factors which cause intracellular to extracellular shift of potassium, or if there is further decrease in potassium excretion. So what are these factors? So what are the conditions where they can have increased intake? It can be because of dietary intake or intravenous intake of potassium, or potassium salts of the several drugs which the patients are taking. It can also be because of blood transfusion, because we know potassium levels go up in banked stored blood, especially more so with older blood. Similarly, gastrointestinal hemorrhage can also lead to increased potassium levels. What are the factors which cause intracellular to extracellular shift of potassium? Drugs like succinylcholine, beta blockers, metabolic acidosis, sepsis, catabolism, insulin deficiency. So all this can lead to hyperkalemia by shift of potassium. Similarly, other factors which decrease potassium excretion include presence of constipation or the intake of some drugs like potassium sparing diuretics or the angiotensin converting enzyme inhibitors or heparin. So in patients who have a fall in GFR, even though they don't have a baseline hyperkalemia initially, any of these factors can push them into hyperkalemia. So why are we worried so much about hyperkalemia? Mainly because of the risk of cardiac arrhythmias. So based on the serum potassium, different levels of ECG changes happen. So when the serum potassium is 5.5 to 6.5 milliequivalents per liter, which is mild hyperkalemia, we have peaked T waves and prolonged PR segment. Once the level goes up a little more, 6.5 to 8 milliequivalents per liter, or it's moderate hyperkalemia, there is loss of P wave with prolonged QRS complex, ST elevation, and we can start having ectopic beats and escape rhythms. Further increase in potassium, say it becomes more than 8 milliequivalents per liter, severe hyperkalemia, there is a progressive widening of the QRS complex with sine waves. The patient can have ventricular fibrillation, asystole, and bundle branch blocks. So these are all the changes which can happen in the ECG because of hyperkalemia. So it's very important to treat hyperkalemia. Urgent treatment when the level is moderate to severe is with intravenous calcium gluconate or calcium chloride. Calcium gluconate will have lesser calcium, elemental calcium, compared to calcium chloride. Calcium chloride has approximately 3 times more elemental calcium than calcium gluconate. That makes calcium chloride more of an irritant when it is given intravenously. So the more commonly used preparation is calcium gluconate. Similarly, glucose insulin mixture is given where 10 units of insulin is added to 25 grams of glucose, and this is run over 20 minutes. So this also helps in bringing the potassium down. Similarly, sodium bicarbonate, by correcting the acidosis, corrects the hyperkalemia. We can also hyperventilate a mechanically ventilated patient to bring down the potassium, because hyperventilation will cause respiratory alkalosis and that will bring the potassium down. Beta-2 agonists like salbutamol nebulization can be used. And of course, dialysis is the best treatment for hyperkalemia in patients who are already on dialysis, patients with chronic kidney disease, and potassium binding resins are used. So this is all about hyperkalemia. Moving on to hypocalcemia and hyperphosphatemia. Why does this happen? Whenever there is chronic kidney disease, there is a reduced renal phosphorus clearance leading on to hyperphosphatemia. In addition, chronic kidney disease is associated with release of the hormone fibroblast growth factor. This is increased levels of this is released from the osteocytes, from the bone. And kidney disease per se can reduce 125 dihydroxy vitamin D levels, and hyperphosphatemia and increased FGF will also decrease the 125 dihydroxy vitamin D, which is necessary for absorption of calcium. So because vitamin D is reduced, now there will be hypocalcemia. The hypocalcemia, reduced vitamin D, and hyperphosphatemia result in stimulation of the parathyroid gland, resulting in secondary hyperparathyroidism that will lead on to renal osteodystrophy and bone demineralization. The other very important problem we see in chronic kidney disease patients is metabolic acidosis. We know kidney is involved in the excretion of protons as ammonium and dihydrogen phosphate, and this proton elimination is associated with bicarbonate reclamation and bicarbonate generation. So whenever there is chronic kidney disease, we have reduced functional kidney. So inability of the kidney to excrete this acid load results in metabolic acidosis. It is quite common. It's seen in 30 to 50% of individuals once the GFR falls less than 30 ml per minute. It's generally defined by a serum bicarbonate less than 22 millicoulomns per liter. And metabolic acidosis can easily be aggravated by other conditions like hypovolemia and hypotension. There are several consequences of this of metabolic acidosis. The metabolic acidosis itself can cause more bone demineralization. It can also cause decreased protein synthesis and muscle mass loss. It can result in insulin resistance, and it also causes worsening of the residual renal function. Besides that, we also know metabolic acidosis results in myocardial depression. It can cause coagulopathy. It can cause hyperkalemia. It will result in reduced effects of catecholamines, and can affect drug pharmacokinetics. So it is of concern to us as anesthesiologists. From electrolyte and fluid, let us move on to hypertension, which is one of very common features seen in patients with chronic kidney disease. Now, the reason why chronic kidney disease patients have hypertension is, the first reason is because there is plasma volume expansion with sodium and water retention. Secondly, there is progressive arterial stiffness. And there is also activation of the sympathetic nervous system and the renin-angiotensin-aldosterone system. So all this is going to lead to hypertension. 86% of patients with CKD have hypertension compared to just 29% in the general population. So one of the very common features which is seen in chronic kidney disease. And this hypertension is bad because it worsens the kidney disease further, and it also leads to increased risk of cardiovascular complications. So it's very important in a chronic kidney disease patient to have BP targets. So if you look at the KDIGO guidelines, it depends upon the extent of albuminuria. If the albuminuria is only of the A1 grade, then we can allow a little higher blood pressure. The blood pressure target is less than 140/90. But once they start having more albuminuria and they fall into A2 and A3 categories, it becomes very, very important to keep the blood pressure less than 130/80 to prevent further progression of the chronic kidney disease and to prevent cardiovascular complications. So what are the cardiovascular complications we are likely to see in a patient with chronic kidney disease? Chronic kidney disease directly affects the heart in several ways. Traditionally, the presence of diabetes mellitus and hypertension. Diabetes mellitus is the commonest cause of chronic kidney disease. So most patients with chronic kidney disease will be diabetic, and diabetes can affect the cardiovascular system. Hypertension can be a cause of chronic kidney disease. It is also an effect of chronic kidney disease, and hypertension can affect the cardiovascular system. And dyslipidemia is very common in chronic kidney disease, and that can affect the heart. Now, there are newer, more and more factors which have been found to be associated with chronic kidney disease that affect the heart. What are these? The presence of volume overload, electrolyte imbalance, anemia, the sympathetic hyperactivity, the renin-angiotensin-aldosterone system activation, the endothelial dysfunction, the pro-inflammatory milieu, the vitamin D deficiency, the oxidative stress, which are all seen in chronic kidney disease, have adverse effects on the cardiovascular system. So what are these cardiovascular manifestations which are seen? The commonest one is a left ventricular hypertrophy, which is both because of a pressure overload and because of a volume overload. Why is there a pressure overload in chronic kidney disease? Because they have hypertension and they have accelerated atherosclerosis. Why is there a volume overload? Because they have sodium and water retention. They could be having an AV fistula for dialysis, or they could be anemic. So all this results in a volume overload. Another common finding in these patients is diastolic dysfunction. So they do not tolerate hyper or hypovolemia. Ischemic heart disease is very, very common in patients with chronic kidney disease. This is because there is decreased plasma triglyceride clearance in chronic kidney disease, which leads to accelerated atherosclerosis. The hypertension also is a reason for IHD. The fluid overload and arterial calcification also increases the incidence of ischemic heart disease. Besides this, they can also have uremic cardiomyopathy, uremic pericarditis. Cardiac failure can happen because they are hypertensive, they have fluid overload, they have anemia, they have acidosis, they have presence of high flow AV fistulae created for dialysis access. So all this predisposes them to cardiac failure. Similarly, they are very prone for arrhythmias because of hyperkalemia, because of acidosis. Also, they can have conduction abnormalities because of myocardial fibrosis. So these are all the cardiovascular manifestations. Moving on to the respiratory system. What are the pulmonary manifestations? They are very, very likely to have pulmonary edema. Why is this so? There can be increased hydrostatic pressure because of fluid overload or left ventricular failure. There can be decreased oncotic pressure because of hypoalbuminemia. There can be increased pulmonary capillary endothelial permeability because of chronic inflammation. Similarly, they are likely to have pleural effusions. They are likely to hyperventilate because of the metabolic acidosis, increased lung water, and poor pulmonary compliance. The next very important system which is affected in patients with chronic kidney disease is the hematological system. If we look at the RBCs, all these patients are going to have anemia. It's mostly a normocytic, normochromic anemia. Now, why is anemia common in patients with chronic kidney disease? This is because we know kidney is the source of, primarily the source of erythropoietin. So in chronic kidney disease, there is going to be decreased erythropoietin production. In addition, there can also be decreased RBC lifespan with increased hemolysis because of uremic toxins. Third, uremia itself can result in bleeding as well as a coagulopathy. The fourth reason is nutritional anemia is very common in these patients because of iron, B12, and folate deficiency. They can also have bone marrow suppression by uremic toxins or bone marrow fibrosis because of secondary hyperparathyroidism. Hemodialysis can also result in anemia. So these are all the reasons why they have anemia. But one advantage is there are some compensatory changes with this anemia to make sure oxygen delivery is not affected to the tissues. What are these compensatory changes? There is an increase in cardiac output. The less viscosity of blood improves the microcirculation. There is increase in 2,3-DPG, which shifts the oxygen dissociation curve to the right. And the metabolic acidosis also shifts the oxygen dissociation curve to the right. So they tend to tolerate anemia. It's a chronic anemia. They tolerate it better compared to an acute anemia. Moving on to the leukocytes. So there are a lot of defects in leukocytes in the cell-mediated and humoral immunity. Leukocyte phagocytosis, chemotaxis, everything is affected. This increases the susceptibility to infections. Moving on to the platelets. Platelet numbers are generally not affected in chronic kidney disease, but platelet function is affected. So they have what is called as a qualitative dysfunction in platelets. This is because there is a disturbance in the platelet alpha granules. So these platelet alpha granules normally secrete von Willebrand factor, fibrinogen, coagulation factors, and fibronectin. So because there is a disturbance in the platelet alpha granules, there is going to be a decreased von Willebrand factor, which can affect the platelet function. In addition, there is also deregulated arachidonic acid metabolism with impaired synthesis and release of thromboxane A2. That's another reason why platelet function is affected. The third reason is there is excessive nitric oxide production from the endothelial cells. This can again result in defects in platelet aggregation. And of course, dialysis per se can result in platelet activation with decreased activity. So most of these patients will have a normal count with platelet count with normal prothrombin time, partial thromboplastin time, and INR. The only abnormality could be an increase in bleeding time and evidence of clinical bleeding like GI bleeding, epistaxis, etc., saying that a person who is well dialyzed and well preserved does not have much of a coagulopathy in chronic kidney disease. So what is the treatment of coagulopathy of uremia? Dialysis is one treatment. The use of DDAVP, that is 1-diamino-8-D-arginine vasopressin. This helps because it increases the release of the von Willebrand factor. So it increases the circulating levels of the factor VIII von Willebrand factor complex. So it is given in a dose of 0.3 microgram per kg and starts working within 1 hour of injection. Similarly, conjugated estrogens have been used in the treatment of coagulopathy of uremia. Cryoprecipitate has been used because we said there is basically a factor VIII von Willebrand factor deficiency. Erythropoietin actually helps in treating the coagulopathy of uremia. How is this so? Erythropoietin increases the RBC levels. So once you have increased RBC levels inside the vasculature, the RBCs push the platelets closer to the walls, closer to the vascular endothelium so that the platelet endothelial interaction becomes better. Another reason is hemoglobin is known to scavenge nitric oxide. So this is how use of erythropoietin and increase in the hemoglobin level actually leads to better platelet aggregation. Moving on to the gastrointestinal system, there can be delayed gastric emptying, anorexia, nausea, vomiting, and upper gastrointestinal hemorrhage. The neuromuscular manifestations, they can have encephalopathy, seizures, tremors, myoclonus. Peripheral polyneuropathy is seen. A distal symmetrical mixed sensory and motor polyneuropathy is seen in CKD patients, characterized by paresthesias and weakness of the lower extremities. Another very important thing is they can have autonomic neuropathy, and that is of very great significance to the anesthesiologist. Moving on to the endocrine, we already spoke about secondary hyperparathyroidism, glucose intolerance, hypertriglyceridemia, then they have increased atherosclerosis. So something called the Uremic Syndrome. What is this? It is just a constellation of signs and symptoms like this: anorexia, nausea, vomiting, pruritus, anemia, fatigue, and coagulopathy. And it's because of the failure of the kidney to excrete uremic toxins like urea, paracresol, and beta-2 microglobulin. So the BUN concentration is a very useful clinical indicator of the severity of the uremic syndrome and the patient's response to therapy. So the treatment for someone who's in uremia and uremic syndrome is to restrict proteins, to decrease the protein catabolism and urea production, combined with dialysis to remove this urea and uremic toxins from the circulation. So that's all about pathophysiology and effects of chronic kidney disease and different organ systems. Now let's move on to pharmacology. What is the effects of chronic kidney disease on drug pharmacokinetics? That's very important to us, especially in relation to our anesthetic drugs. Effects are because of effects on clearance, effects on volume of distribution, and effects on protein binding. So clearance can be altered in chronic kidney disease. If the drug has metabolism in the liver, but the metabolites are active and they are not excreted by the kidney, the active metabolites can accumulate. The volume of distribution can be altered because of change in fluid balance. We said there is albuminuria, so the plasma protein levels are low. So because of this reduced protein binding, the drugs which have excessive protein binding, increased protein binding, they will have an increased drug-free fraction and pronounced effect. So let's look at one group of drug now. If you look at the opioids, fentanyl is one of the common drugs which we use. It undergoes extensive hepatic metabolism. It does not have any active metabolites. 7% is excreted unchanged in the urine. But the decrease in plasma protein binding can increase the free fraction, resulting in a prolonged sedative effect with fentanyl. What about morphine? 70% of morphine is metabolized to morphine 3-glucuronide, but 5% is metabolized to morphine 6-glucuronide. And this morphine 6-glucuronide has analgesic properties. Its elimination depends on renal function. So its half-life is prolonged in chronic kidney disease. And that is the reason we do not choose morphine as an analgesic in patients with chronic kidney disease. What about pethidine? Again, it is metabolized to norpethidine, whose excretion is dependent on kidney. And in chronic kidney disease, norpethidine will accumulate. And this is neurotoxic. It can cause seizures, myoclonus, and altered mental state. That is why we do not use pethidine also in chronic kidney disease. What about tramadol? 30% is excreted unchanged in the urine, and it has an active metabolite that is excreted by the kidney. So the action is prolonged. So the dosing interval has to be increased for tramadol. So the best opioid to choose for intraoperative anesthesia for a patient with chronic kidney disease would be fentanyl. Moving on to the intravenous induction agents. Thiopentone, there is reduced protein binding in chronic kidney disease. So there is higher drug-free fraction. So we have to titrate it to effect. Propofol pharmacokinetics is unaltered by chronic kidney disease, but this also has to be titrated to effect. What about benzodiazepines? Midazolam is metabolized in the liver. The main metabolite is 1-hydroxymidazolam, and that has sedative activity like the parent compound. And this and all the other conjugated metabolites of midazolam can accumulate in renal failure, especially with infusions, leading on to a prolonged sedative effect. So a single dose of midazolam is probably all right, but infusions of midazolam is going to have prolonged sedation in patients with chronic kidney disease. What about dexmedetomidine? Its pharmacokinetics, it's not influenced by renal impairment, but the sedative effect may be stronger because dexmedetomidine is quite highly protein bound, some 94%. So free fraction will be more in patients with chronic kidney disease. Moving on to the neuromuscular blocking drugs. Succinyl colon. Succinyl colon can be used provided there is no hyperkalemia. We know succinyl colon increases the serum potassium by 0.5 millicoulomb per liter. So as long as the serum potassium is less than 5.5 millicoulomb per liter, it is okay to use succinyl colon in chronic kidney disease. Of course, there is reduced action of plasma cholinesterase, but clinically the action is not much prolonged. What about vecuronium? 40% is excreted by the kidney. So the 3-hydroxy metabolite accumulates in renal failure. It has 80% of the potency of vecuronium. So it will result in prolonged effect. Rocuronium again, 10 to 20% is excreted by the kidney, but there are no active metabolites. Again, it can be prolonged, rocuronium. So the best neuromuscular blocking drugs to use are atracurium and cisatracurium because they are not dependent on the liver or on the kidney. They undergo Hoffman elimination. And so these are the drugs of choice in chronic kidney disease. The only thing to remember is atracurium metabolism leads to laudanocin, and especially with infusions of atracurium, the laudanocin levels are likely to go up. They will not be excreted in the presence of chronic kidney disease. And the laudanocin has been found to be neurotoxic. This is one thing we need to remember when you're using prolonged infusions of atracurium in patients with chronic kidney disease. Reversal drugs, neostigmin, renal excretion accounts for 50% of the plasma clearance of neostigmin. Clearance is reduced in CKD and half-life is prolonged. Moving on to the inhaled anesthetics. Sevoflurane, a lot of controversy with sevoflurane and nephrotoxicity. Metabolism of sevoflurane leads to elevated inorganic fluoride levels. And it has been found that if the fluoride level is more than 50 micromoles per liter, it has been associated with renal damage in animals, but this has not been seen in humans. The second thing about sevoflurane is sevoflurane reacts with carbon dioxide absorbance to form compound A, and this compound A has been found to be nephrotoxic in rats. The nephrotoxicity has not been established in humans. Even so, many countries have an upper limit saying sevoflurane cannot be used with fresh gas flow less than 1 liter per minute or less than 2 liters per minute. But we regularly use sevoflurane, including with low flow anesthesia. So there is no proof that sevoflurane causes nephrotoxicity, either because of compound A or because of fluoride levels. So it is not contraindicated in chronic kidney disease and it can be used. Desflurane and isoflurane are also safe to use in patients with chronic kidney disease. A word about the analgesics. Acetaminophen is safe. We know non-steroidal anti-inflammatory drugs are not safe to be used in chronic kidney disease because they decrease the renal prostaglandin levels because they are cyclooxygenase inhibitors. They decrease the levels of prostaglandins and they cause a decrease in GFR. They can also cause an acute interstitial nephritis as part of an idiosyncratic reaction. Plus, they also increase the risk of GI bleeding. So, NSAIDs are contraindicated in patients with chronic kidney disease. We'll take a break again now for some questions.
Yes, ma'am, a very, very engaging lecture. And regarding the questions, I encourage all the listeners to type in the answers, because once they commit an answer to a question, they are engaging themselves, and right or wrong, I think they'll be able to remember it. So this question is: end stage renal disease refers to a GFR of less than A, 5 milliliters per minute per 1.73 meters square, or is it B, 10 ml per minute, C, 15 ml per minute, or D, 30 ml per minute? There are a lot of answers, ma'am, and most of them are C. Dr. Manasa K was the first to answer.
Yes, 15 ml per minute is correct. I think by mistake, I've moved to the next slide.
No problem, ma'am. The next question is: which of the following is true? So, cisatracurium leads to more laudanocin formation than atracurium. B, midazolam has no active metabolites, and so infusions with midazolam do not lead to prolonged sedation in CKD. 70% of morphine is metabolized to the active metabolite morphine 6-glucuronide, which accumulates in CKD patients. Or D, sevoflurane does not lead to nephrotoxicity and can be used for maintenance of anesthesia in CKD patients. So which of the following is true? So yeah, there is a mixed response, but there is a brisk response. There are quite a lot of people who have answered. Some believe it is C. There are D's and A's also in the chat box, ma'am.
Okay. So the answer is, if you look at A, cis atracurium leads to more laudanose formation. That is wrong, because cis atracurium leads to less laudanose formation.
Yes.
B, midazolam has no active metabolites. That is wrong. We did talk about the 1-hydroxy metabolite, which leads to prolonged sedation. So B is also wrong. 70% of morphine is metabolized to morphine 6-glucuronide. That is wrong. The second part is correct, that morphine 6-glucuronide accumulates, but only 5% of morphine is metabolized to morphine 6-glucuronide. 70% is metabolized to morphine 3-glucuronide. So C is also wrong. Sevoflurane does not lead to nephrotoxicity and can be used for maintenance of anesthesia in CKD patients. D is the correct answer.
Yes, you explained about those experiments in the rats with sevoflurane and the flows.
Yeah, it has only been found in animals. In nephrotoxicity has not been shown with sevoflurane in humans.
Human patients. Correct, ma'am.
Yeah. So we'll go to the next question.
Next question, yes. So the next question is, which of the following drugs does not lead to hyperkalemia? A, angiotensin receptor blockers, B, tacrolimus, C, alpha 2 agonists, or D, heparin. So which of these drugs does not lead to hyperkalemia? Yes, we have C, alpha 2 agonists, and D, heparin. There is C and D are the mostly. There is an occasional A also, ma'am. So, but mainly it is C and D that the response that I can see in the chat box.
Okay, so the answer is C. Alpha 2 agonists like clonidine and dexmedetomidine do not lead to hyperkalemia. The angiotensin receptor blockers do cause hyperkalemia. Tacrolimus causes hyperkalemia. Heparin also causes hyperkalemia. So we'll go to the next question.
Yes, the next question is, calcium is used to treat hyperkalemia because A, it pushes potassium from extracellular to intracellular space. B, it increases renal elimination of potassium. C, it antagonizes the cardiotoxicity of hyperkalemia by stabilizing the cardiac cell membrane. Or D, all of the above. Yes, I think Dr. Lakshmi was the first to answer, and C is the predominant answer that we have. Occasional D also, ma'am, but I think most of them have answered C, antagonizes the cardiotoxicity of hyperkalemia by stabilizing the cell membrane.
So the D is just to confuse. So the C is the correct answer. It is a physiological antagonist of potassium. Calcium is a physiological antagonist. So it antagonizes the cardiotoxicity of hyperkalemia by stabilizing the cardiac cell membrane. That is the correct answer. Okay, I think we'll go to the lecture now again.
Yes.
So now we move to the actual part of anesthetic management of a patient with chronic kidney disease. So if you look at management of a patient with chronic kidney disease, usually they are on restricted protein intake. Usually the protein intake is 0.6 to 0.8 gram per kg per day. They are also on a restricted salt intake, less than 1.5 to 2 grams of salt per day. They will be on antihypertensives. They will be on diuretics to treat the hypervolemia. We said they have calcium and vitamin D deficiency, so they will be on calcium and vitamin D supplements. We said they have hyperphosphatemia, so they are likely to be on phosphate binders. They have metabolic acidosis, so they will be on bicarbonate, and they will be on erythropoietin to treat anemia, and statins usually to treat the hypertriglyceridemia. Regarding renal replacement therapy as management for these patients, there are two types of dialysis, hemodialysis and peritoneal dialysis, which are used as renal replacement therapy for these patients with chronic kidney disease. And of course, we have renal transplantation as the renal replacement therapy. An important thing to remember is, compared to dialysis versus transplantation, transplantation is the treatment of choice. Actually, it is better to do the transplantation preemptively before starting dialysis for the patient. The outcomes are even better. So transplantation is usually done when the estimated GFR is less than 20 ml per minute per 1.73 meters squared, and there is a progressive, irreversible deterioration over 6 to 12 months. A word about hemodialysis. Hemodialysis requires a stable access to the bloodstream for dialysis to be performed. So usually 3 different types of vascular access are used by nephrologists to do the dialysis for the patients. Primary AV fistulas, AV grafts, or tunneled hemodialysis catheter. Generally, access is placed in the non-dominant upper extremity because lower extremity placement results in two problems. One is an increased risk of infection, and the second is the problem of arterial steal syndrome. So now AV fistulas are different from AV grafts. In AV fistulas, the vein is joined to an adjacent artery directly. The advantage of AV fistulas, these are the first choice for dialysis because they have long-term patency rates. They have lower infectious and thrombotic complications, but then it takes around 4 to 6 weeks to mature. So from the time of doing the AV fistula, it will take at least 1 to 1.5 months to start using it for the purpose of hemodialysis. What about AV grafts? Here, it is not a direct connection between the artery and vein, but there is a prosthetic graft that is connecting the artery to the vein. Usually it is made up of polytetrafluoroethylene. The problems with AV graft is the long-term patency is inferior to AV fistula, and there is a 6 times greater thrombosis rate and 10 times greater infection rate. But the advantage is it can be used earlier within just 2 weeks. Mostly what happens is they will start off with AV fistulas. If the fistula fails, they try in one hand or they try in the other hand, they try radiocephalic, brachiocephalic, and brachiobasilic. If there is fistula failure, then they come for AV grafts. Hemodialysis catheter can also be used for dialysis. So usually it's a double lumen catheter like this of a good size. It's a good diameter. It's usually used for temporary vascular access till the AV fistulas undergo maturation. Usually the right internal jugular vein is chosen. Generally the subclavian vein is not chosen for placing hemodialysis catheters because there is a very high risk of stenosis which is associated with subclavian cannulas. So usually the right IJV is the commonest site for the hemodialysis catheter. The catheter diameter should ideally be only 1/3 of the vein diameter. So what are the indications for dialysis? When will we recommend a dialysis? If the patient has pericarditis or pleuritis, or if the patient has CNS related symptoms, uremic encephalopathy or neuropathy with confusion, asterixis, myoclonus and seizures, or if there is clinically significant bleeding diathesis, which is attributable to the uremia, of course, fluid overload, which is refractory to diuretics, hypertension that is poorly responsive to antihypertensive medication, persistent metabolic disturbances, which are refractory to medical therapy, like hyperkalemia and metabolic acidosis, and persistent nausea and vomiting. So all these are the indications for dialysis. So if you look at the process of dialysis, the first one was from the IJV, and this is from an AV fistula. Basically, the blood is pumped through an extracorporeal system that incorporates a dialyzer. In the dialyzer, blood is separated from the dialysate, which is a crystalloid solution, by a semi-permeable membrane. The solutes move across the membrane along their concentration gradient by diffusion. So dialysis, the method is by diffusion, and they move from an area of higher concentration to an area of lower concentration. So the uremic patient has lots of urea and high levels of potassium in the blood. So urea and potassium will move from the blood to the dialysate, and bicarb is added to the dialysate so that bicarb can move from the dialysate to the blood to correct the metabolic acidosis. Typically, the hemodialysis session, it's an intermittent hemodialysis. Usually it takes 3 to 4 hours, and it results in 65 to 70% reduction in the blood urea nitrogen. There are some problems which are associated with dialysis. Volume-related problems can be there. Excessive fluid removal can result in hypovolemia, hypotension. Solute mediated, there can be electrolyte shifts and alchemia. Patients can have arrhythmias. Anticoagulation related, patients can have bleeding. And there's something called the dialysis disequilibrium syndrome, which is neurological symptoms occurring during dialysis because of rapid removal of urea. So this reverse urea effect is because of the fact that the urea concentration remains elevated in the CNS because of slower diffusion from the CNS than from the removal from the blood. So what happens is there is going to be, because of this osmotic gradient, water moves into the brain and it results in cerebral edema. When you compare dialysis versus renal transplantation I already said is a better option because it improves the quality of life and long-term survival, and it is also a more economic option in the long run. So if you look at this chart, comparing patient survival after dialysis and renal transplantation. What you see in the blue line is a patient on dialysis, whereas the red line is after transplantation. So you find that at 5 years or 10 years, the patient survival is much better after a renal transplantation compared to maintaining them on dialysis. So with that background, let us go to anesthetic management of a patient with chronic kidney disease for renal transplant. If you look at the current trends in kidney transplantation in India, some 7,500 transplants are done across 250 centers in India. 90% are from living donors and 10% is from deceased donors. So this is the global observatory of transplantation. You find that in the year 2020 alone, there were 5,486 kidney transplants done in India. So the source of this donor kidney can be a deceased donor or it can be a living donor. Deceased donor can be of two types. It can be brainstem dead but heart beating, or it can be a non-heart beating donor. So with the deceased donor, it is an urgent procedure because there is a limited viability of the donor kidney. Whereas with the living donor, it is an elective surgical procedure. There are different types of deceased donors are available. This is called the alphabet soup of kidney transplantation. SCD is standard criteria donor. ECD is extended criteria donor. DCD is donation after cardiac death. So a standard criteria donor is a 35-year-old man with no history of diabetes and hypertension, where the cause of death is a motor vehicle accident. Extended criteria donor refers to a donor who is more than 60 years old or 50 to 59 years with two of the following. The cause of death is a cerebrovascular accident, pre-existing history of systemic hypertension, or if the terminal serum creatinine is more than 1.5 milligram per deciliter. So the extended criteria donor, why is there a difference? You find that with the extended criteria donor, there is 70% increased incidence of graft failure. Even so, it is not possible to have standard criteria donor for so many patients waiting for renal transplant. So the extended criteria donor at least gives some hope and some better quality of life compared to dialysis. So although the risk of graft failure is more with extended criteria donor, the ultimate mortality is much lesser when you compare this with dialysis. What about donation after cardiac death? This is a donor in whom cardiac function has stopped before the organs were procured. So what happens if you have a kidney from a DCD, donation after cardiac death? So because the kidney perfusion could not have been maintained, delayed graft function is more common with such type of donors, with the DCD donors, compared to a standard criteria donor. It's around 50%, whereas for a standard criteria donor, the delayed graft function is only around 20%. So this is the reason we need to know whether the kidney is coming from the standard criteria donor, extended criteria donor, or donor after cardiac death. What about preservation of the deceased donor kidney? It is done by static cold storage at 0 to 4 degrees centigrade. The kidney is immersed in a preservative solution. So it is immersed in cold storage because the hypothermic environment decreases cellular metabolism. And the preservative solution decreases cellular metabolism and also provides some amount of cytoprotection. So different preservative solutions are available. The original one was the Collins solution, which was modified as the Euro-Collins solution. Then you have the University of Wisconsin solution. Then you have the HTK solution, which is histidine, tryptophan, and alpha ketoglutarate, which is called custodial. In all these solutions, the kidney can be preserved for a period of 24 to 48 hours. So this is the composition of the different solutions used for kidney preservation. So you find that the Euro-Collins solution and the University of Wisconsin solution have very high potassium levels, whereas the HTK solution has only lower potassium level. It also, this is what we commonly use in our hospital for renal transplant. We use the HTK solution, which has potassium, sodium, chloride, calcium, magnesium, mannitol, histidine as the buffer, mannitol, tryptophan, and alpha ketoglutarate as the antioxidants, and it has histidine and tryptophan. So this is the composition of the various preservative solutions which are used for storing the kidney. That is about deceased donor. Now we'll move on to living donor. The advantage of living donor is it increased donor pool is available, plus it is an elective procedure, so the timing of an operation is more flexible. Another more important reason is kidneys transplanted from living donors show an increased graft survival. So what you see in blue is a deceased donor kidney. What you see in red is the living donor. So the graft survival is much better with living donor kidney compared to deceased donor. So living donors are all carefully evaluated. The donors should have a GFR more than 90 ml per minute per 1.73 meters squared, and they should not be having an albuminuria. So the albumin excretion rate of the donor should be less than 30 milligrams per day for them to be able to donate their kidney. So this is again the KDIGO guideline for exclusion criteria for living donors. Who are the people we do not choose to donate? Age less than 18 years, GFR is less than 60 ml per minute, proteinuria, uncontrolled hypertension or hypertension with end organ damage, type 1 diabetes mellitus, microscopic hematuria not due to reversible causes, IgA nephropathy, high risk of thromboembolism, significant medical illness in the donor, and autosomal dominant polycystic kidney disease. So if the donor has any of these diseases, they are not taken up for living kidney donation. So once we exclude all this and we choose a proper donor, the next step is going to be the donor recipient matching. Now, matching has to be done to ensure immunological compatibility so that the transplanted kidney, the allograft, is not rejected. So there are 3 steps to this. The first is the blood group matching for ABO compatibility. The second is tissue matching for HLA compatibility for the 6 antigens of the major histocompatibility complex. Also, 6 antigen match represents the best compatibility with the lowest risk of rejection. The third step is a cytotoxic cross match, which is done between the recipient serum and the donor T cells. The purpose of the cytotoxic cross match is to detect the presence of antibodies in the recipient against the donor cells. So after cross-matching, the recipient is also screened to exclude the presence of severe coronary artery disease, peripheral vascular disease. They undergo lung function tests. They undergo screening for tumors. They have an endoscopy to rule out acid peptic disease, and they have to have good diabetic control. On the recipient side, what are the contraindications? When can you not take the recipient for renal transplantation? If they have active infection, active malignancy, active substance abuse, if the kidney failure is reversible, if they have uncontrolled psychiatric disease, if the predicted patient survival is less than 2 years, these are all absolute contraindications for transplantation. The relative contraindication is if the recipient has some systemic condition that has caused a kidney failure, like primary oxalosis or systemic amyloidosis with cardiac involvement. The other relative contraindications are the presence of severe cardiac and pulmonary disease in the recipient. For example, the recipient has a history of myocardial infarction in the last 3 to 6 months, or has progressive symptoms of angina that is not amenable to angioplasty or bypass surgery, or severe coronary artery disease which is not amenable to any intervention. If they have severe ischemic cardiomyopathy, normally they can have ejection fraction of 30%. It is okay with dialysis. If it improves it is fine. But if they have ischemic cardiomyopathy, then that's a contraindication. Similarly, pulmonary conditions, if they are on home oxygen therapy, they have uncontrolled asthma, they have severe cor pulmonale, severe COPD, lung fibrosis, restrictive disease, and hypoxia, they are generally not taken for transplantation. So with all that, let us move on to anesthetic management of renal transplant, which we will look at pre-operative preparation, intraoperative management, and post-operative care. Pre-anesthetic assessment history, we specifically have to ask for history of breathlessness, pedal edema, chest pain, and palpitations, because many of these patients, in between their dialysis sessions, if the dialysis is not adequate, they are likely to have breathlessness. And we said they are at high risk of ischemic heart disease. So we do have to look for these symptoms. We have to ask for the patient's functional capacity. Generally, the exercise tolerance will be decreased in most of these patients. We also have to know what is the cause of the chronic kidney disease, what is the duration of the chronic kidney disease, does the patient also have diabetes, hypertension, coronary artery disease, what is the usual daily fluid intake, what is the daily urine output, is there any residual renal function? So if the patient, in spite of having chronic kidney disease, is not yet anuric, they are able to make more than 100 ml of urine over 24 hours. It is supposed to have some residual renal function they are supposed to have, and they have better outcomes. Next, we also have to look at the pre-anesthetic assessment, the medication history. All of these patients are antihypertensives, and many of them will be on 4 to 5 antihypertensives. It could be AC inhibitors and angiotensin receptor blockers. They could be on diuretics, calcium channel blockers, beta blockers, alpha-1 blockers like prazosin, alpha-2 agonists like clonidine. So they could be on multiple antihypertensives, and they could be on bicarbonate for metabolic acidosis. We need to get everything about the details about the dialysis. What is the type of dialysis the patient is having? Is it a peritoneal dialysis or hemodialysis? What is the site? Is it from an AV fistula, AV graft, or an internal jugular vein? What has been the duration of dialysis? This is very important because longer the duration of dialysis, there is going to be concern about vascular axis like stenosis and thrombosis of central veins, or they had multiple AV fistulas and grafts. Venous axis, peripheral venous axis will be a problem in these patients. We need to know about the frequency of dialysis. Is it once, twice, or thrice a week? When was the last dialysis? The body weight before and after dialysis. Then we have to do a proper examination of the patient. Whether the patient is pale, whether there is any bleeding tendency is there any edema, if they are fluid overloaded. The properly dialyzed patient will not be edematous, will not have a bleeding tendency. Similarly, if the patient is treated for anemia, they are very unlikely to be having pallor. We also have to look for hypertension, whether it is under control. We have to check for autonomic neuropathy, flow murmurs. The respiratory system, we need to look for signs of fluid overload, which means they need to be dialyzed. The location of the AV fistula and the dialysis lines, and we do a thorough airway assessment. Investigations for transplant, we need a complete blood count. We have to look at the hemoglobin because most of these patients can be anemic. We have to look at the WBC count because there could have been infections. We also have to have a baseline platelet count. We have to look at the blood urea nitrogen, creatinine, electrolytes, especially potassium, sodium, calcium, and bicarbonate. We have to look at the coagulation profile, PT, PTT, INR. Liver function test is also normally done before transplant. A chest X-ray will tell us the presence of cardiomegaly, pulmonary edema, and pleural effusions. ECG will tell us the presence of ischemia, arrhythmias, left ventricular hypertrophy, conduction blocks, and hyperkalemia. And we need an echocardiography to look for the presence of regional wall motion abnormalities, the ejection fraction, and the presence of a pericardial effusion. So preoperatively, we need to optimize these patients for elective surgery. We have to correct the anemia. So most of these patients will be on erythropoietin. Epoetin alpha is generally given in a dose of 20 to 50 international units per kg, 3 times a week, subcutaneously or intravenously. If the hemoglobin is less than 10 grams per deciliter, they can also receive darbepoetin, 0.45 microgram per kg once a week, subcutaneously or intravenously. A point to remember about erythropoietin is it will increase the risk of hypertension, stroke, and vascular access loss. The acceptable hemoglobin for most transplants is 10 to 11.5 grams per deciliter. We also have to make sure their blood pressure is corrected and optimized. The blood sugar is optimal. Usually it is 6.5 to 8% is the HbA1c for these patients. We also have to correct the coagulopathy. If they're adequately dialyzed, they are very unlikely to have a coagulopathy. We have to optimize their cardiac and pulmonary condition. Preoperatively, on the day before the transplant, they undergo a dialysis 24 hours before. Minimum 6 hours is needed between dialysis and start of surgery to optimize the fluid and electrolyte and acid-base balance to avoid any hyperkalemia or metabolic acidosis. We continue the antihypertensive and cardiac medications, but generally the AC inhibitors are withheld to decrease the risk of intraoperative hypotension. We do give them acid aspiration prophylaxis with H2 blockers like ranitidine and also with metoclopramide. When we're doing a live transplantation, the live donor nephrectomy and renal transplant operations are commonly performed sequentially in adjacent theaters with minimal delay to reduce the ischemic time of the donated kidney. For the donor, the nephrectomy can be done by laparoscopic or open procedures. The patient will be in the donor is in the lateral decubitus position with the bed flexed like this to expose and arch the flank. So we have to make sure there is no nerve damage, pressure source, airway compromise, or venous access compromise. Usually the left side is preferred for the donor nephrectomy because there is better surgical exposure and there is a longer vascular supply of the left kidney. If you look at anesthesia for laparoscopic donor nephrectomy, it is a general anesthesia with endotracheal intubation and controlled ventilation. Commonly, the patient receives fentanyl, propofol, and vecuronium and maintenance with air, oxygen, and sevoflurane. The most important thing is to have a good venous access, because they need to have adequate hydration to maintain adequate renal perfusion of the kidney which is going to be removed and the other kidney which is being left behind. So 10 to 20 ml per kg per hour of balanced salt solutions are used. We have to maintain perfusion pressure, normoxia, normocarbia, normothermia, and urine output of at least 100 ml per hour. To improve diuresis, mannitol and furosemide can be given before the clamping of the renal artery. The kidney is then perfused in cold preservative solution and then taken to the recipient. The donor can be extubated end-op. For pain, we usually avoid NSAIDs. We can give paracetamol, IV PCA with fentanyl or morphine, and regional anesthesia can be given especially for open donor nephrectomies, paravertebral block, TAP blocks, quadratus lumborum blocks, or thoracic epidural analgesia. For laparoscopic donor nephrectomy, usually it is less painful. Moving on to anesthesia for recipient, do we use a general anesthesia or a neuraxial anesthesia? General anesthesia is commonly administered because of some concerns with neuraxial anesthesia. What are these concerns? We know neuraxial anesthesia is associated with sympathetic blockade and hypotension, and we don't want the transplant recipient to have hypotension because that can affect graft function. The second problem, we're talking about uremic coagulopathy. So neuraxial block cannot be given in the presence of coagulopathy. And third is sometimes the patient feels uncomfortable being awake, especially at the time of reperfusion. So usually it is not done solely under neuraxial anesthesia. Even though if an epidural is put, it's put for post-operative pain relief. So usually a general anesthesia is given. An epidural is sometimes placed for post-operative pain relief, provided there is no coagulopathy. What about vascular access? We need a very good peripheral vascular access in transplant surgery because we'll be giving large volumes of intravenous fluids rapidly during the renal transplantation. So obtaining access can be difficult in patients on dialysis. We need to avoid the hand, which has the IV fistula for IV access. Generally, the hemodialysis catheter should not be used for purposes other than dialysis, like for drug administration or CVP monitoring. Exception is emergency situations or when alternative vascular access is impossible. Then we can use the dialysis line, but we have to maintain absolute asepsis. Care of the AV fistula is very important during the transplant surgery. So this was actually the transplant which we did today morning. The patient had a fistula in the left hand. So all the NIBP cuff, the SpO2, the IV line, everything will be on the right hand. And the AV fistula hand is generally padded to avoid injuries. What about monitoring? Standard monitoring for all renal transplant patients is ECG, pulse oximetry, central venous pressure, temperature, non-invasive blood pressure, end-tidal carbon dioxide, FiO2, and anesthetic agent monitoring. Of course, neuromuscular monitoring and urine output monitoring. One important thing to remember is we don't put in an arterial line so easily. I mean, there has to be a definite indication for putting an arterial line. The patient has uncontrolled hypertension, or the patient has a cardiac condition which warrants placement of an arterial line. Only then we put in an arterial line. And even so, we avoid upper limb arteries. The reason for this is in case the transplant is not, the kidney is not working, for future AV fistulas, we need these arteries. So that is the reason there is a high threshold for invasive blood pressure monitoring. We generally try to avoid putting an invasive blood pressure unless it is definitely warranted. We can also go for escalated monitoring depending upon the extent of cardiopulmonary involvement of these patients by using non-invasive cardiac output monitoring and transesophageal echocardiography. Central venous pressure is commonly used for monitoring the CVP during the renal transplant. It is by using a triple lumen cannula in the right internal jugular vein. Subclavian vein is avoided, as I said, because of the risk of stenosis. Femoral is avoided because of two reasons. One, of course, femoral is associated with infection. Second, the renal artery and renal vein are going to be anastomosed to the external iliac vessels. So this is another reason why we do not put any cannula in the femoral vein. Many of these patients, if they've had dialysis catheters in the neck, right side, left side, both sides they could have had, they can have pre-existing venous stenosis because of these long-term indwelling catheters. So we have to be prepared in these patients for a difficult central venous cannulation. They could have thrombosis or they could have stenosis. Usually an ultrasound guided cannulation has to be done with strict aseptic precaution, and CVP is used to guide fluid therapy, start vasoactive medications as well as for blood sampling. Induction and intubation, pre-oxygenation. A rapid sequence induction and intubation is warranted in patients who have autonomic neuropathy. Otherwise, it is not necessary. Usually, injection fentanyl is given, titrated to effect 1 to 2 microgram per kg, followed by propofol, again titrated to effect. The range is 1 to 2 milligram per kg. Succinylcholine can be given if the potassium is less than 5.5 millicoulombs per liter. We can also give atracurium or cis-atracurium for intubation, especially if you're not worried about full stomach. Atracurium, the dose is 0.5 milligram per kg, and cis-atracurium is 0.15 milligram per kg body weight. Many of these patients are hypertensive, so it is important to attenuate the intubation response using preservative-free lignocaine 1.5 milligram per kg 90 seconds before intubation, or injection esmolol 0.5 milligram per kg IV. Intubation with a cuffed oral endotracheal tube. We have to make sure antibiotic, broad-spectrum antibiotic is usually administered at the start of the transplant. Induction immunosuppression is also given at this time. The most important thing to remember is we have to use short-acting drugs in these patients and titrate doses to effect. Maintenance is usually with air, oxygen. We can use sevoflurane, desflurane, or isoflurane and give top-ups of atracurium and fentanyl. We have to maintain normal PO2 and normal PCO2. We have to maintain perfusion pressure. We cannot have a fall in systolic blood pressure or mean arterial pressure to more than 20% of the baseline. The usual target mean arterial pressure during renal transplant is more than 90 to 95 millimeters of mercury for two reasons. It preserves residual renal function, and the more important reason is it ensures adequate graft perfusion. So if the mean arterial pressure is not adequate, it can result in delayed graft function and the need for post-operative dialysis. We have to maintain normothermia using forced air warmers and fluid warmers. These patients are highly prone for thrombosis. So we also have to use TED stockings and Flotron, and their skin is quite fragile. So paddings and gels have to be used. The incision for renal transplant is called the Gibson incision. It is a curvilinear incision in the lower right abdomen to facilitate placement of the renal allograft in the right iliac fossa. So this is how the cleaning and draping is done. So that is the incision which you can see in the right lower quadrant of the abdomen, a curvilinear incision of 20 to 25 centimeters long. So this is again a video showing the bed. So you see you can see with the sutures, what is being held is the external iliac vein, and you can appreciate the pulsation of the external iliac artery. The bed is ready to receive the renal allograft. You can see the pulsation of the external iliac artery. So it is all ready. They are just preparing the kidney for the transplantation. So the renal artery is anastomosed to the external iliac artery, and the renal vein is anastomosed to the external iliac vein, and the ureter is anastomosed to the recipient urinary bladder. So it is a ureteroneocystostomy. Ischemia time is something we need to be aware of, because prolonged ischemia time will result in delayed graft function. So that's three ischemia times which we talk about: the warm ischemia time at the time of harvesting, the cold ischemia time, and the warm ischemia time at the time of transplantation. So what is this warm ischemia time at the time of harvesting? So this is the time from the clamping the renal artery in the donor to the time of efflux of cold perfusate from the renal vein. Cold ischemia time refers to the time from cold perfusate coming out of the renal vein till the kidney is placed in the recipient for anastomosis. And the warm ischemia time at transplant time is from the time kidney is placed in the recipient to the completion of anastomosis and clamp release and the beginning of reperfusion. Fluid management is very important in renal transplant, because hypervolemia will lead to fluid overload and pulmonary edema, whereas hypovolemia will result in impaired perfusion of the transplanted kidney. So what is the volume of fluid that we administer? Adequate volume for the renal allograft to function. So how do we know this volume is adequate? Usually a CVP guided volume transfusion has been the traditional approach. It involves intraoperative infusion of fluid to maintain a CVP of 9 to 10 millimeters of mercury. This is usually 1.5 to 2.5 liters of crystalloids. 30 to 40 ml per kg are administered at the time of clamp release. Dynamic indices of fluid responsiveness like pulse pressure variation, systolic pressure variation, and stroke volume variation are also now being increasingly used to titrate fluids in the perioperative period for transplantation. What about the type of fluids? Traditionally, to avoid hyperkalemia, only 0.9% saline was used as the crystalloid of choice in chronic kidney disease patients undergoing renal transplantation. Then they found that large volume infusion of normal saline resulted in hyperchloremic acidosis, renal vasoconstriction, hyperkalemia. So nowadays, only balanced salt solutions, either ringalactate or plasma light are recommended for infusion during renal transplantation. This is a recent Cochrane database of systemic reviews, which came in 2016, which looked at comparison of normal saline versus lower chloride solutions for kidney transplantation. And the conclusion was that balanced electrolyte solutions are associated with less hyperchloremic metabolic acidosis compared to normal saline for renal transplantation. So fluid management is a very important part of renal transplant. The next important part is hemodynamic management for best graft function. So as I said earlier, the CVP is usually 9 to 10 millimeters of mercury. This is what is recommended at the time of clamp release. Similarly, blood pressure at the time of clamp release has to be a mean arterial pressure more than 90 millimeters of mercury. We have to remember that this renal allograft is denervated. It has no auto-regulation. So if the blood pressure is not adequate, the perfusion will get affected and the graft will not function. Adequate hydration with crystalloids, 30 ml per kg per hour at time of clamp release. So this has to be infused by the time the anastomosis is complete. Sometimes there can be a fall in BP at clamp release. This can be because of vasodilatation. This is because of reperfusion after the ischemia. The mediators which accumulate during ischemia enter the circulation, but this can easily be managed. Mannitol and Lasix are sometimes given to the transplant recipient to improve graft function. This is usually not routinely done in living donor kidneys. It can be given in deceased donor kidneys if there is no urine output at the end of the anastomosis. There is no evidence as of now to support the use of dopamine. It was originally used. It was believed that it improved renal blood flow. Dopamine is no longer being used during renal transplantation. So if you find that in 90% of live kidney donation and 50% of cadaveric donation, immediately urine output will start coming at the end of the anastomosis release. A word about immunosuppression. Allograft survival depends upon host immune system modulation. A lifelong immunosuppressive regime is required after renal transplantation. Immunosuppression is induction therapy and maintenance therapy. Induction is intense short-term immunosuppression during the perioperative and immediate post-operative periods. Maintenance immunosuppression is continued in the post-operative period, usually with triple therapy. So what is induction immunosuppression? This is by using T-cell depleting monoclonal or polyclonal antibodies or by using an interleukin-2 receptor antagonist. Maintenance immunosuppression can be by using corticosteroids, that is methylprednisolone, prednisone, or prednisolone, calcineurin inhibitors like cyclosporin and tacrolimus, antimetabolites like mycophenolic acid and azathioprine, or the mTOR receptor inhibitors like everolimus and sirolimus. So commonly what we do is we administer anti-thymocyte globulin as induction immunosuppression. So this anti-thymocyte globulin is a polyclonal antibody obtained from equine or rabbit cell lines by immunizing them with human thymocytes, getting the polyclonal sera, pasteurizing it and getting it in a lyophilized powder form. The dose is 1.5 milligram per kg per day. It is given as an infusion over 6 hours, diluted in 250 ml of normal saline before the donor kidney is placed. So usually this anti-thymocyte globulin is administered by the anesthesiologist at the time of induction. So one thing to remember is this is associated with cytokine release because it is from an equine or a rabbit product. So it is from an animal. So it results in some amount of reaction like anaphylaxis with bronchospasm, hypotension and tachycardia. So we have to be aware of this. So methylprednisolone given 1 gram prior to giving the ATG prevents these cytokine release symptoms. Basiliximab is the other antibody. It's a monoclonal antibody that is also usually administered by anesthesiologists. Either ATG or basiliximab is used. So these lymphocyte depleting agents are usually used only in patients with high immunological risk. Like there's a high number of HLA mismatches, the panel reactive antibodies are there, or blood group incompatibility is there, or there's a young recipient with potent alloreactivity, because it has been shown that with these lymphocyte depleting agent, the rejection is much lesser. So methylprednisolone, 1 gram is diluted in 100 ml of normal saline. If ATG is not given, then methylprednisolone is usually given at the time of venous anastomosis. But if ATG is given, it is given along with ATG at the time of induction itself. A word about vasopressors. Generally, ephedrine and phenylephrine are not recommended to treat hypotension because we don't want vasoconstriction of the renal allograft. But if there is severe hypotension, which is not responding to other treatment, we can start norepinephrine because maintaining perfusion pressure becomes a more important task there. What about blood transfusion? It is generally not recommended for renal transplant recipients because it causes alloimmunization. The best is to correct anemia preoperatively with erythropoietin, and chronic kidney disease patients generally tolerate anemia as well. So a transfusion trigger of 7 grams per deciliter should be used. So if it's more than this, we should not be transfusing. Mostly there's hardly any blood loss. So it is unlikely we will need blood transfusion unless something happens at the time of anastomosis and some injury is there, then major blood loss occurs. Then we have to remember that the blood we transfuse, we have to give it using a leukocyte filter or use leukodepleted blood. So besides alloimmunization, the other problems of blood transfusion are hyperkalemia, increased blood viscosity, and transmission of infection. So this is a picture what you see on the right side of a leukocyte filter. Normal blood cell filter is 170 microns. It does not filter the leukocytes. So this is a 40 micron pore filter, which is used specifically for filtering leukocytes, or you can get leukodepleted blood directly from the blood bank. End of the surgery, if the kidney is functioning well, most patients can be extubated on table after reversal of neuromuscular blockade. We have to ensure adequate analgesia. Regarding post-operative care, these patients are taken care of in a dedicated post-transplant unit. Fluid management, again, is very, very important for continuing graft function. Usually 50 ml per hour is added to the last hour's urine output as a baseline. Of course, based on CVP, BP, and daily weights, the fluid is adjusted. Hemodynamic management is again very important. We have to avoid any post-operative hypotension because that can result in delayed graft function. Analgesia is usually IV PCA with opioids like fentanyl. If the kidney is working, then we can also give morphine. If we put an epidural, we can use that for analgesia. TAP blocks have also been used for analgesia, but we avoid NSAIDs. So we have to monitor the urine output, renal function test, electrolytes, and continue the immunosuppressive medication. Most of these patients are on triple immunosuppressants immediately after the transplant. Usually they'll be on mycophenolate, tacrolimus, and corticosteroids. That is the triple immunosuppressive therapy which they have as maintenance therapy in the post-operative period. Thromboprophylaxis, early mobilization, and mechanical thromboprophylaxis is recommended. Some complications can happen perioperatively. There can be acute rejection, which is quite unusual if we do the matching before itself. If the cross-matching was done properly and the patients are on immunosuppression, acute rejection has become quite an uncommon complication. They can have vascular complications like renal artery and vein thrombosis, ureteric complication. The more common issue is a delayed graft function, which means there's a failure of the transplanted kidney to function promptly after transplantation, requiring dialysis within 1 week of transplant. So this is with living donor, delayed graft function is quite less. It's 4 to 10%. It's more high with deceased donors. And it's usually because of ischemia reperfusion injury or immunological processes. So acute tubular necrosis is one of the most common factors for delayed graft function. So the deceased donor kidney could already be injured. One important thing to remember is if the warm and cold ischemia time are prolonged, then that can result in delayed graft function. If the hemodynamic status we do not maintain of the recipient during the clamp release, like we don't maintain perfusion pressures or if we don't give adequate fluids, then it is possible that the graft will not function and there can be delayed graft function or there can be reperfusion injury. So with that, we come to the end of this class. So to conclude, chronic kidney disease is associated with effects on multiple systems, especially cardiovascular system, fluid and electrolyte balance, acid-base balance, hematology, and the central nervous system. Renal transplantation definitely improves the quality of life and survival. Preoperative preparation and optimization is important. Appropriate donor and recipient selection is important. Appropriate intraoperative care is important. We especially have to concentrate on immunosuppression, fluid management, and hemodynamic management. We also have to remember post-operative care. So I do have a few questions at the end of this now.
Yes, ma'am. That was such a brilliant lecture. I think you can just take a glass of water. But as we can discuss some of the questions. So this question number 8, the intraoperative fluid of choice during renal transplant. I mean, before I finished, there have been answers on the chat box, ma'am. So they are,
so I'm happy they've been listening.
Yes, yes. They are engaged. 0.9% normal saline plasma light, albumin, hydroxyethyl starch. And most of them believe it is B for Bombay, plasma light.
Excellent, excellent. I'm so happy.
Yes, ma'am. Dr. Manu Kumar was the first to have started the answers.
Very good, very good. I'll go to the next question.
They need to be applauded. Next question. All of the following are effects of erythropoietin therapy, except, so which is not an effect of erythropoietin therapy. It increases the risk of thrombosis, it decreases blood viscosity, it leads to hypertension, it improves platelet function, and the chat box is filled with B. B for Bombay. So, yeah, so I believe That should be the answer. Yes.
Very
Yeah.
good, very good. Two more questions are there. That's all.
Yes. So the next question is: all of the following are intraoperative targets during renal transplantation, except a mean arterial pressure of more than 90 mmHg, B, CVP of 10 mmHg, C, blood transfusion to improve hemoglobin to more than 10 grams per deciliter to improve graft oxygen delivery, or D, adequate hydration with 30 ml per kg per hour of crystalloids. So yes, all of you are encouraged to answer, and most of them are answering C for Calcutta, blood transfusion to improve hemoglobin to more than 10 grams per deciliter.
Very good, very good. So that is one which has to be avoided. Okay, question 11. This is the last question, I think.
Yes, this is the last question. So the last question is, which of the following immunosuppressants enhances the effects of muscle relaxants? Hiran Shah believes it is A, tacrolimus, mycophenolate, prednisolone, or cyclosporine. So there is a mixed response for this one, ma'am.
Yeah, because I didn't discuss this in the presentation. We cannot blame them.
Okay. So which of the following immunosuppressants enhances the effects of muscle relaxants? Is it tacrolimus, mycophenolate, prednisolone, or cyclosporine?
Okay. Is there any D?
There is a D, IV Meena, Dr. IV Meena.
Very good. Congratulations. So cyclosporin is the correct answer. Cyclosporin is the immunosuppressant that has been shown to prolong the effect of non-depolarizing muscle relaxants.
Okay, so the answer is cyclosporin, and that was such a wonderful lecture, ma'am. It was.
Thank you so much. Shall I stop sharing, Dr. Nishant?
Yes, ma'am. We can stop sharing. There are a few questions in the chat box. If you permit, we can just take these questions from some of the participants that we have.
Definitely, definitely.
So the first question, ma'am, is related to the duration of prolonged atracurium infusions. Dr. I. Ming wants to know what is the duration for it to classify as a prolonged atracurium infusion. Is there any specific duration
So what is the problems which they faced with elevated laudanum has been in patients usually after almost 48 hours of infusion with atracurium. So if you're going to restrict it to less than 48 hours, this has not been a problem.
Okay. Okay, ma'am. So that means it is approximately 48 hours for that one.
Yes.
There is Dr. Harsha Bhatia wanted to know about something about peritoneal dialysis. What could be the indications and certain disadvantages of peritoneal dialysis?
So the indication for peritoneal dialysis is someone who cannot tolerate the hemodynamic shifts of hemodialysis. That is what. So usually patients with unstable angina and severe cardiovascular disease, they are the ones who are recommended for peritoneal dialysis. And the problem with peritoneal dialysis is, of course, it increases the risk of peritonitis and infection. That is the most common problem which happens because of peritoneal dialysis. Okay,
and any other disadvantages, ma'am, in that are obvious? No.
The advantage of the peritoneal dialysis is that it can be done at home itself, because nowadays ambulatory peritoneal dialysis has come. So for us hemodialysis, you have to come to the hospital. So it is more cumbersome. So that is another reason why people choose peritoneal dialysis, because with ambulatory peritoneal dialysis, their lifestyle is more comfortable compared to coming to the hospital 3 times a week and staying there for 4 to 5 hours to get the hemodialysis done. That is the other difference. But most patients, I've not seen many adults having peritoneal dialysis. Most of them do have hemodialysis. The ones who come for transplants in our hospital, most of them are on hemodialysis with AV fistulas or AV grafts.
Right. Dr. Leo wants to know whether there is any specific reason for not using nitrous oxide during maintenance.
So the general thing itself, we are not using nitrous oxide. Forget transplant surgery, we are not using it in general for most of the patients because of the greenhouse effect and all that. There is no specific contraindication. It just increases the incidence of nausea, vomiting, pulmonary artery pressures might go up. There's not a contraindication. You can use it for renal transplant if you want. It is not a contraindication. It is just that out of practice, most of us have gone into air oxygen mode now. We don't use nitrous oxide so frequently intraoperatively. Dr. Naveen Malhotra has joined, I think. Hello, namaste. Guys, we missed you.
Namaste, namaste, madam. Namaste. When Nishant briefed me, it is going on very excellently. Congratulations. Please carry on with the questions. I'll join in. I'll put my words soon.
Yeah.
Nishant, continue.
Yes, sir. Yes, sir. So there's been a very comprehensive lecture and very nice. Dr. Sirisha, what we'll do is once all the questions are over, we will allow the participants to unmute themselves so they can ask their questions on their own. So Dr.
Yeah,
Sirisha,
sure.
after the session, Dr. Sirisha wants to know about half NS now. What is the context? We'll allow her to ask herself. In the meantime, Dr. Coims wanted to know what is the crystalloid of choice in CRF patients. What would be the crystalloid of choice?
Usually we use plasma light. If you have ringer lactate, you can use ringer lactate also. Normal saline is no longer used, especially continuously only normal saline. Some people do alternate normal saline with ringer lactate. The aim is not to overload the patient with too much of normal saline. So you can do ringer lactate few pints, normal saline few pints, only ringer lactate or only plasma light. Any of that therapy, volume therapy is acceptable.
So balance salt solution would do. Dr. Suvetha wanted to know about the legal documents anesthesiologists should check before a transplantation.
So usually the transplant comes through an authorization board through the organ transplant committee. So they usually have this authorization letter, and they also have a separate consent for transplant. So make sure the authorization letter, the governmental approval letter is there, and make sure that the consent is there.
Yeah, the consent will be there. And I think amongst the last questions is by Dr. Ayameen about the role of GTN in recipients. What would be the role of glycerol trinitrate in?
So the thing is, if sometimes with uncontrolled sometimes even with 4 or 5 antihypertensives, they could be coming with very high blood pressure. Elective transplants, usually we don't take them unless their blood pressure is optimized. But say their cadaver kidney has come and this patient is HLA matching, everything is done, this patient is ready. And then the blood pressure is high. You can't cancel the transplant just because the blood pressure is high. So in such situations, we have used nitroglycerin to bring the pressures down, and you can take the patient up for transplant. So elective procedure, don't do it. But an emergency cadaver kidney has come, then to control the blood pressure, you can use NTG.
Right, ma'am. And there is another, Dr. Apurv Naveen wants to know about the role of intraoperative albumin transfusion in renal transplant recipients.
So most of these patients, if they are well prepared, then they do not have a very significant low albumin. Usually it's more than 3 grams, and they do not require any intraoperative albumin therapy. Just therapy with crystalloids is enough. If you want to use a colloid, then albumin is we cannot use hydroxyethyl starch because it is associated with renal injury. So albumin has a much better safety profile, but make sure that the volume transfusion shouldn't result in pulmonary edema. Make sure the kidney is functioning when you are administering volume, because if the albumin is in and the kidney is not going to be functioning, they can easily go into pulmonary edema.
Absolutely. And another question has come up by Dr. Leo regarding hypothermia in the recipients. So
we have to prevent hypothermia in the recipient by active warming steps which we take. So commonly we use the fluid warmer for warming all the intravenous fluids. We'll be giving rapidly crystalloids, 1.5 to 2.5 liters over 1.5 hours. So it's important to make sure it goes through a fluid warmer so the crystalloids are warm. We also use a convective forced air warming, the bear hugger. It is always important to avoid hypothermia and maintain normothermia in the recipient. That is also important for graft function. Any hypothermia is going to cause vasoconstriction. It is going to cause increased bleeding tendency. It will delay metabolism of all drugs. It will worsen the cardiac events. So it's important to avoid hypothermia, maintain normothermia in the transplant recipient by taking active steps like that.
Yes, ma'am. And Dr. Hiren Shah, he wants to know, after the press syndrome in recipient patient, how much time should we wait for transplant in the recipient?
Press is reversible encephalopathy syndrome. So once it is reversible, I'm not sure if there is an exact timeline between disappearance of press and when you can take for transplant. As long as the patient is it's reversed and the patient is neurologically fine. Press is more of a clinico-radiological syndrome where you have evidence of edema by MRI. So probably if edema has subsided and the patient does not have any clinical symptoms, I think you can take the patient ahead for transplant.
Right, ma'am. So what we can do is we can request all the listeners, if they have any questions that they want to ask themselves, or if they want, if I have not been able to frame or present the question the way they wanted, they can ask ma'am directly themselves. So if there are any questions, you are encouraged to unmute yourself and ask the questions directly. In the meantime, thank you so much, ma'am. It was such an excellent lecture with the images and the videos of your institute. And in one of the ultrasounds, I saw the date of today also. So
Yeah, this was, I mean, all the photos were actually today morning we had a live renal transplant.
yeah.
So I just took photos of that patient and put it today.
Very nice. If there's anybody who wants to ask any
Nishant,
question.
I'd like to take this opportunity to thank Madam for delivering an excellent talk.
Thank you.
Nishant, am I audible?
Yes, sir.
Yes,
You are
sir.
audible, sir.
And
Your voice is breaking a little, sir. Oh, his voice is.
I think.
I'm sorry, ma'am. I could join only in the later half. Take another class. Yeah, my network is not stable as I'm traveling.
Your voice is breaking, sir. Yes.
Yeah, my network is not stable as I'm traveling. So I once again thank Madam for sharing her valuable time with us. And I hope she will join us soon for another excellent class like today's one.
Thank you so much, Dr. Naveen. It was my privilege to be a part of this. It was really an honor. And I should thank Dr. Nishant also for conducting it so seamlessly.
Sir. So, if we have your permission, sir, we can end.
Yeah, please.
Right. So formally, thank you so much, madam. And
thank you, madam. Thank you very much. So nice of you.
Thank you so much.
Thank you, ma'am. And this lecture of 1.5 hours, I mean, it is worth so many more hours of the books. I'm sure everybody who listened to the lecture today and who will be able to listen to the lecture on the YouTube later on, see the lecture later on, they'll be very well benefited. So with the sir's permission, I think we can end the session now. Thank you, all of you. Thank you, ma'am. And thank you, sir.
Thank you so much. Thank you, Dr. Naveen. Thank you, Dr. Nishant. Thank you.
Thank you.
Thank you to all the delegates for their patient listening. Thank you.
Thank you, ma'am.